Hello and welcome to today's webinar, The Dark Side of the Rainbow, AOD Issues for LGBTIQ. My name's Phoebe Bailey and I'm one of the Education and Training Officers at Turning Point in the Workforce Development Team, and I'm going to be your facilitator for today's webinar. Before we begin the webinar, I would like to acknowledge the traditional owners of this land upon which the presenters and participants are located and pay our respects to their elders and the elders of other Aboriginal communities. In today's webinar, we're going to be exploring the concerns and risks for those from the LGBTIQ community with AOD issues and the barriers many of this group of clients have in accessing AOD health services. Through a case-based approach, you will learn about appropriately addressing the health needs of LGBTIQ clients. Before we get started, and I introduce our presenter for the day, Dr. Kary Alexander, I just wanted to remind you that the webinar will run for about 45 minutes. You are most welcome to ask questions throughout the webinar, and you can do this via the chat box at the bottom left-hand corner of your screen. Halfway through the presentation, we will stop, and if we've got questions, we'll ask Kary to respond to some of your questions, and then again we'll spend about 5 or 10 minutes at the end of the webinar with question time as well. The PowerPoint presentation is available via the document folder on the right-hand corner of your screen, so you will see an icon which represents the document folder, and in this folder you will also find the Trans and Gender Diverse Reference Guide that was developed by VAC in collaboration with VADA. And of course, if you are having any technical issues, Redback is here to help you out. So today I'm delighted to introduce Dr. Kary Alexander, Addiction Medicine Specialist and Director of Addictions Training at Turning Point. As an out-and-out proud lesbian, Dr. Kary is a strong advocate for LGBTIQ quality care in both the AOD sector and health services. She was one of the first graduates to complete the addiction training program of the Royal Australasian College of Physicians to obtain fellowship of the Australasian Chapter of Addiction Medicine in 2007. She has recently been appointed to the Victorian Government's LGBTIQ Task Force for Health and Human Services. So Kary, a big warm welcome to you, and now I'm going to hand over to you to begin the presentation for the day.
Well, thank you, Phoebe, and thank you everyone for having me here today. So I thought we'd start with a case, and the case we're going to do is a case of a man who I'm going to call Mr. BJ, and I welcome any questions. This is a great opportunity for the next 35 minutes to ask any questions. No question's a wrong question, no questions are off limits. If we can address it, we can. We'll do our best. So this case is just to kind of get us all thinking a bit. So Mr. BJ is a 43-year-old businessman. He's married to a woman. He lives with his wife and their 2 young children. And he presents to a drug and alcohol service for assistance because he's concerned about problematic methamphetamine and GHB use. When the assessment's done, it becomes apparent that there's no other significant alcohol, drug or gambling history, but that he's very clear that he's requesting help because his GHB and methamphetamine use has really spiraled out of control. He's concerned that it's affecting his moods, his work performance. It becomes apparent that he's neglecting his parenting duties, and it's detrimentally affecting his relationship with his wife. And he was at a chill-out party recently where a friend overdosed, and he told you this because that's what triggered him to come to an alcohol and drug service, because he's actually concerned for his own safety risk of an accidental overdose. So I just want us all to be thinking, what could be going on? You know, what, as alcohol and drug professionals in an alcohol and drug service, if someone comes in with a story, what are the kind of, there's so many things to consider, but what are the kind of things we could consider in this context? So I really want people to start thinking and to type in any questions or ideas or suggestions. No suggestions or questions are wrong. what I'm wondering is going on is this chemsex. And here's some images from that. This one's about drugs spilling sex, and chemsex parties are often called chill out parties. And we're going to talk more about chemsex later, but I think it's a really big, when things get out of control, it can be a really big health issue. And alcohol and drug services and health professionals are best positioned to respond and support people where this has become an issue. So keep thinking about this, keep sending questions, but we are going to talk more about chemsex, but at the end of the session I really want everyone to feel comfortable and confident dealing with a patient who's experiencing or talking about chemsex. Some of the things, I'm sure most of you are well aware that there's so many different terms, but it's just good to just have a quick reminder and refresher about some of the terms we need to be thinking about in our patient population, as well as our colleagues and co-workers about languages. So for instance, the term same-sex attracted can be a very useful broad term, because if someone is actually same-sex attracted, they may or may not identify with any other word, such as gay or lesbian or bisexual. It's really important to be aware of what bisexual is and that it's real. And personally, I cannot speak on behalf of any populations other than my population of myself. But what I am, I'm listening and valuing input from other experts, and what I'm hearing is that often people that identify as bisexuals have additional layers of barriers to multiple things and have poorer health outcomes as a result of the lack of supports and invisibility. A really useful definition for people is the term transgender and gender diverse. Remember, this is separate to sexuality. So regardless of whether or not, if someone's transsexual or gender diverse, they may or may not identify as same-sex attracted. They can be very different matters. The term intersex, we're going to go into that definition later, but it's really important to be very clear what that is, because often that's quite invisible, misunderstood, and lumped together as under the transsexual umbrella as well, and there may be some overlap but some distinct differences as well. Some people use the term queer as an overarching umbrella term. Some people personally hate that term and would never identify with it. Another term which is, sorry, I'll just skip back, which is we're going to be hearing more and more as the conversation in health systems about trans and gender diverse people becomes more important, conversal, I suppose, like there's more and more discussion because the health issues are being recognised, is the term cisgender. And what that means is someone that identifies with the gender they were assigned at birth. So, for example, I identify as a woman and female, and I was a baby girl. So that's cisgender. It all lines up, and I have all sorts of privileges as a cisgender as compared to someone who may be intersex or trans or gender diverse because of that in our society. Another terminology I'm sure you're all well aware of, it's good to have a refresher, is homophobia. And the best definition I personally found of that isn't actually a fear of homosexual people, it's actually a disgust of homosexuality. And we all were highly exposed to that in multiple facets of media late last year through the marriage postal survey for same-sex marriage equality. Last year there was way too much of that going around, in my opinion. Another useful term which is used interchangeably is, it's just a useful framework to keep in our mind. It's not seldom used, but it's a great concept. And that's the concept of heterosexism, which is also interchangeably referred to as heteronormative. So the easiest way to think about this is that often there is a blind or unspoken or even unconsciously thought of assumption that all our patients are heterosexual, unless proven otherwise, and that we treat everyone as if they're heterosexual, and that systems are designed on the assumption that everyone's heterosexual. So, for example, often in health systems or hospitals, the paperwork registration forms is written on the assumption that someone falls under being heterosexual. Another very useful and essential concept for us in the health system to be aware of is the concept of men who have sex with men, which, if you think about it, is actually like a broad umbrella term. And under all the men who have sex with men, some of them will identify as gay, some of them will identify as bisexual, some of them will identify as heterosexual. And it's very important because someone, like the case of Mr. BJ, might be married to a woman, he's a cisgender man, him and his wife have children. To the outside world, he might look like a heterosexual person, he might call himself heterosexual, but he may be having sex with other men as well. So we can't exclude that just because he's married to a woman. There's an idea in health systems that's really important that we start looking at improving our cultural competency, and this is a constant, ongoing, evolving process for dealing with LGBTIQ people. So it's important to keep in mind the concept that LGBTIQ people experience what's called minority status. And this can be different and unique from ethnic minority status. So a really useful way of thinking about this is that no one as an ethnic minority is alienated from their parents for being different race to them. However, for LGBTIQ people, often their parents aren't LGBTIQ at all, and there is a very real either fear of perceived rejection or, in many tragic cases, significant rejection. So it's compounded minority. It's essential for us in health services and health professionals to develop and improve our cultural competence so that we can best maximise the quality of care for all our patients, including LGBTIQ people. We do know from very good literature, both within Australia and internationally, that the incidence of substance abuse, problematic substance abuse I should say, in these populations are more than 30%, which is higher than the broader population overall. So there's something going on, but this is a health issue, and us in the alcohol and drug sectors, I believe, are responsible to make sure that we acknowledge this health issue and we find out how to deliver good quality healthcare and to minimise barriers to accessing appropriate, competent healthcare. It's also thought that these rates are even higher than 30% amongst young people, and also people that identify as bisexual and transgender, as well as people who are LGBTI and part of an ethnic minority, because they've got the intersectionality of additional factors compounded. It's also well known in mental health that these groups, or these populations as overall, have higher rates of suicide attempts. And why could this be happening? Well, there's different thoughts, but this is something that's been well looked at in the literature, and one of them is that this is a very useful concept. Someone recently pointed out to me at a conference I was at, and they said that instinctively, if you think about it on like an instinctive primal survival level, for humans to survive through millennia, we've had to be part of a pack. We cannot survive on our own. We're vulnerable out in the wild on our own. If we're sick and there's risks of wild animals, we instinctively we know we have to belong to a pack. We have to be able to return to a pack and be welcomed and part of that functionality. So one of the unspoken and often unacknowledged massive stressors that LGBTIQ people often have is that growing up, as they become aware that they fall in this and that they may not be cisgender or may not be heterosexual, is often a sense that I'm of the other. And I personally experienced this as well as a teenager, and this is widely common. So this is also linked to internalised homophobia. So it's been pointed out that when this happens, and it often happens in childhood or in young adolescence, but can happen at any age, that the person experiencing this often is at a primal level got a very instinctive sense that they will not survive if they're rejected from the group. And that group might be their school group, their peer group, their family, their immediate family, their extended family, their church group, their sports group, whatever groups they're part of. And that instinctive thing is absolutely spot on. It's not exaggerated, because they're right. If we aren't connected, we cannot thrive and survive as human beings. So that's quite a massive thing, and often that coincides with adolescence, when people are often experimenting with substances, and that can help to numb that incredibly distressing fear. Keep bringing on the questions, folks. I want people to start thinking. Also, there's another school of thought, and this may or may not be true, but it's interesting to consider, and that is that the entree to the LGBTI community. So if an individual realises that they want to connect with other people who are not cisgender or not heterosexual, it's often through social events, so nightclubs, bars, parties, and in those contexts it's standard to use alcohol, if not other drugs. This is in some ways similar but then different to the heterosexual world, because in the heterosexual world, yes, all that's happening, especially young people, but also heterosexual individuals are able to spend time with other heterosexual people without having to go to those events that might be at home or in their neighbourhood or at school or at church. Some more points around why there are such high prevalence rates includes that there's, as a population overall, the individuals who are LGBTIQ have higher rates of psychological distress. For an individual that may not be the case, but overall, because of the rejection or fear of potential rejection from multiple groups, ostracism, which is often very real, especially from the most loved ones someone should be able to turn to in their hour of need, like close family members. Also, the reality of being discriminated against, and tragically these populations, and this is my thoughts, I cannot speak on behalf of others, but my own thoughts is I am particularly concerned about trans and gender diverse people being fully harassed in public by strangers. There's been many cases publicly known where people have had to seek police help, assistance, and then not necessarily been treated appropriately by the police. Also, there's higher rates of homelessness among these groups, often because they've been rejected and ostracised by key people, and when that's going on, people can't thrive academically or at school or at university if parents have cut off their funding, etc. Also, it's thought that some people, if they're dealing with that internalised homophobia, or they might have just been raised to have disgust of homosexual people and then discover they're homosexual, so they're disgusted with themselves, or the pain of the fear of rejection. Often, some people tell us that their experience is to be able to actually be a full adult, which includes being a sexual human being, and to be able to connect with other people romantically or sexually, they actually have to disassociate from the yucky feelings, and to do that they use chemicals such as alcohol, drugs. So going back to the concept of the minority stress model, this is a useful model that if you apply it to LGBTIQ Australians, this will just clarify part of the inequalities experienced in this population. So this particular model proposes that poorer health outcomes in minority groups can be partly attributed to stressors caused by living in a hostile, or in this case a homophobic or transphobic or biphobic culture. Minority stresses arise from external factors such as discrimination, or internal factors such as the internalised homophobia or the identity concealment. Also, there's minorities within minorities. So, for instance, many bisexual people are teaching, trying to teach us so we can learn from them, saying that even within the LGBTI community, that they experience discrimination because they're often excluded in the heterosexual world, and then excluded by gay or lesbian people because they're not validated as gay or lesbian because they're not, but their sexuality is dismissed. Like they might be told, oh, you're not really attracted to women, or you're really heterosexual, or you really, haven't made up your mind yet. So invalidating and dismissing their identity. Also within the LGBTI communities, often there's discrimination against trans and gender diverse people, and even ethnic minorities within it. So there's layer upon layer upon layer of discrimination. There's a growing body of evidence to suggest that minority stress is extremely common amongst LGBTIQ Australians, and their health outcomes are suffering as a result. So I believe as AOD professionals, we're all in the health system, and this is something we can advocate for at any level within our services. And poor health outcomes for LGBTIQ Australians are compounded by reduced access to healthcare because of multiple barriers. Let's get back to chemsex. So, chemsex is the term used for a phenomena which has probably been around for millennia, of people getting together to enjoy some sexy fun times and using alcohol or drugs to do it. Particularly at the moment in fashion is to call it chemsex, and to use illicit substances, and it varies. Most of the publication and research is done in the UK and Western Europe, and there it's a combination of methamphetamine and GHB and methadone. But in Australia it tends to be a combination of GHB, methamphetamine use and cocaine, so all used as a cocktail all at the same time. A study done in the UK, there's been no equivalent study in Australia, so this is the closest reference, but it's probably transferable, shows that a survey of men who have sex with men, so these might be the married men, this might be BJ, I think he's out there, being surveyed about chemsex, they're being asked, have you combined illicit substances with sex? And 10%, or more than 10% in the last week, have. So it's very common at the moment. Anecdotally, in Melbourne at the moment, in the emergency departments, we're seeing people presenting with acute problems from chemsex, like accidental overdoses, and anecdotally the ones we're seeing are predominantly heterosexual. But today we're focusing on chemsex parties, particularly men who have sex with men, because it's quite a health issue that we can address. There's an associated increased risk from the substance use, and at these chemsex parties, which are often called chill-out parties, there is a risk of overdoses as well as unsafe sex practices, and there's concerns about HIV transmission as well as transmission of other STIs. So, in reality, what's going on is that what participants, people who are going to these parties, are telling us is they're really easy to find from apps like dating apps or hookup apps on their phone. There's code words about whether or not it's a chemsex party. There's code words about whether or not there's a chemsex party being hosted nearby and you can come right now. And we've got drugs here, or who wants to have a chemsex party, you need to supply the drugs. Some people might exchange money to kind of, contribute to the cost. One of the concerns about this is often when people go to these chemsex parties or are hosting one, in the heat of the moment might not know or check or do the usual safety checks they might do about substances. They don't know where the supply came from. They just have to trust the stranger who's offering it to them. They're taking a cocktail, which is always potentially risky, and often they're with complete strangers. So it's not even good friends they can trust to look after them. And often, from the research that's come out of the UK and anecdotal feedback, often there might be, 10 to 20 people at one of these parties, people dropping in, then leaving. Most men in the survey who have been to chemsex parties said at some point they have known someone to overdose at one. Usually, if not while they were there, someone that they know through their that they've know of has had an overdose at one. So it's very, very common, unfortunately. Another factor that's going on because people are there for sex is people may be having unsafe sex. There's a lot of sex positive messages about using condoms and playing safe and so on. However, men who have sex with men that do not identify as being gay or bisexual are much more likely to not be practicing safe sex. They're much more likely not to be buying condoms or taking condoms, because that's some way to acknowledge that maybe they're not heterosexual and that's too hard for them. So that's the group that BJ falls into, and that's a particularly high risk group because I really worry about them catching or transmitting HIV and then transmitting it to their wives or female partners and potentially transmitting it to their unborn babies. And they're less likely to seek professional help. There's a question that's come in about how many people on average attend a chemsex party. It could easily be 10 to 20 people. And so when one of my colleagues has done a lot of research about this in London, and when he's surveying men who go to chemsex parties but have been using so many substances that it's become, they're at the pointy end, they might have gotten a bit out of control, they're actually seeking professional help either for HIV risk or their substance use. Some of them are saying that in a chemsex party might go on most of the weekend for them. They're probably the hard party goers, and may on most of the weekend for them. They're probably the hard party goers, and may have had sex with 20 different sexual partners, all male, and doing practices that they wouldn't have necessarily done, such as having lots of sex without condoms. Receptive anal sex without condoms is particularly high risk for catching HIV, and also anal fisting, which in itself can increase the risk of transmission of HIV because it can cause micro tears to the rectal mucosa. So if that occurs and then someone has receptive anal sex without condoms, they're at much higher risk of catching HIV. So I've just got, before we go on, we've got another question about, or a comment, which is great to hear that someone's written in that they've spoken to a caller who has described a chemsex club in Melbourne, and yep, they are out there. And I've also been told, when these people are asked why they're going, how come they're doing this, even though they're problematic, their substance use is getting problematic, they're saying because it feels great. And someone was saying it's so amazing they're scared to give it up because they're scared they might not enjoy their sexuality anymore after giving it up. So it's quite an interesting issue. So I think as health professionals, when we have patients come in, we really need to be not judgmental about their sexual practices. We need to be focusing on addressing what their concerns are about their substance use, listening to them, and then ensuring that they know where to get appropriate health for their risk factors, especially for their sexual health. Which brings me to PrEP and PEP, which is similar but slightly different. So many of our drug and alcohol patients who I see, personally I work at Turning Point, so it's I deal with the more complex patients as a specialist doctor, but many of them I see what I find really concerning, have never heard of PrEP and have never heard of PEP and don't know how to access it when I tell them about it, but they're really keen and they're grateful to be told. So the wonderful thing is, and this is an important message to keep in the back of your mind, in Victoria, that if we know of anyone who has exposure that's put them at high risk of potential HIV exposure, that they can dramatically reduce their risk of becoming HIV positive if they urgently phone the number on the screen, the 1-800 number, for PEP, that's post-exposure prophylaxis. They've only got 72 hours from the moment of exposure to start the medication for it to be effective. They phone that number and they'll get screened appropriately and discussed whether or not they are at significant risk to warrant going on the medication. And if they do want to, then they're informed properly about all the potential side effects and risks. But that can dramatically make a massive difference. PrEP, however, is quite different. PrEP is actually a preventative medication to prevent someone catching HIV, and that's for people who are having ongoing risks of HIV transmission, such as men who have sex with men without condoms. And it's saving lives, saving a lot of lives. And the news I got last week was that the Therapeutic Goods Administration in Australia has actually finally approved it for PBS funding, which is fantastic. So now it's accessible. And I'm strongly advocating for any patients who are having sex with men without condoms necessarily to contact the relevant services to discuss for them how to get it. So just it's that number. If anyone's interested, they can just keep that phone number in your mobile phone, so you've always got it in your pocket. So if you ever see any patient in the future, just give them those numbers. It's going to save lives in Melbourne, in Victoria and Australia. Just going to mention briefly before we wind up, because this is LGBTI, it's not just men who have sex with men, that up to 20% of women who identify as lesbian have had sex with a man in the past year. And that's important to note, because if a patient's telling you she's lesbian, just keep in the back of your mind that doesn't mean she doesn't have sex with men sometimes, so potentially she might have an unplanned pregnancy if that's relevant to the treatment. Also, some single, lesbian, bisexual and trans men have unplanned pregnancies. And so this is kind of relevant in our AOD services. So if anyone's potentially pregnant or at risk of an unplanned pregnancy and they've got alcohol use disorder, the current guidelines are to offer them a pregnancy test, because that can then pick up pregnancies early on enough to hopefully prevent fetal alcohol spectrum disorder. It's also essential to know if someone's pregnant before starting naltrexone or Suboxone. So we can't just assume that someone can't be pregnant. And a really respectful way to ask that is to ask the question, is there any chance you could be pregnant? Or are you planning a pregnancy? So there's no judgment there about their sexual practice. I learned many years ago never to ask a patient, are you sexually active? Oh, you need, are you trying to get pregnant? No. Okay, well then you need contraception. No, I don't. And then it turns out that it's a woman having sex with a woman. So instead, I've been trained to use the question, do you need contraception? Which is a very quick way to find out what we really need to know. We do know that for bisexual populations as a whole, there are higher rates of alcohol and drug issues, depression and suicide risks, and that this group's more invisible, which I've mentioned before, because often they're discriminated outside the LGBTIQ populations and then discriminated within various kind of LGBTI situations, and often there's a B in the name, but that's the only time it's addressed. So rejected wherever they are, which is further, a massive tragedy in my opinion, which is one of the reasons why I'm deliberately including it in here. Now I'm going to go into make a special mention of trans and gender diverse people, because the literature is suggesting that this population is at even higher risk of substance use disorders, but there's a paucity of robust research because it's yet to be done, it needs to be done. There was a USA survey which found more than 25% of trans and gender diverse people that responded to their survey reported that they'd misused alcohol or other drugs to cope with the poor treatment related to their gender identity, and that this actually increased to 40% if they lacked external support, employment or financial stability. Now, I really need to make a special mention of intersex because this is included in the term LGBTIQ but often gets misunderstood or misinterpreted as something to do with sexuality, and it's not. So the definition I've used is the definition from the United Nations Office of the High Commissioner for Human Rights, and their definition is that these people do not fit into the typical definitions for male or female bodies. In reality, there's multiple different variations of this, but this might be someone born with an XY chromosome variation, or an XY chromosome and there's an enzyme chain difference that means that they're not responding to androgens at the usual way, so their body might have one set of chromosomes but appear to be a different gender. And this group of patients is historically very discriminated against. I'm going to just make a brief mention that in drug and alcohol sector we see a lot of family violence. A lot of our patients are perpetrators of family violence or victims of family violence, even if they haven't disclosed that, even if they might not identify it as that or label it as that. So we need to be constantly listening for that, and we're going to be talking about that in a webinar later on in the year. But family violence does not discriminate, we all know that. So just keep in mind that if any of your patients or staff members or colleagues or community members are LGBTIQ, they're not immune to family violence. And actually it can be worse in this population because there's a naive assumption that family violence is a heterosexual issue by men perpetrating against their female partners. So when people in same-sex relationships are experiencing family violence and seeking help, they're less likely to be screened, believed, or linked to the appropriate level of legal and professional supports they require. I've just noticed there's been a really good question. Has there been a study done yet of increased substance use during the plebiscite? And the answer to that is, to my knowledge, there hasn't. And however, there is very, very new evidence that shows the significant harm that's come out of that, and a recommendation that a formal recommendation within the government's own research that in future they do not do a plebiscite or postal survey asking Australian voters their opinion on whether or not a minority group should have discriminatory laws changed. So, some practicing tips that we can all do in our workplaces, and one of them is, and these are recommended by the Department of Health and Human Services actually, as well as Gay and Lesbian Health Victoria, which is funded by Department of Health and Human Services. One of them is to put up welcoming symbols such as a rainbow flag or a rainbow flag sticker. I'm a big advocate of the transgender sticker as well, which I'm trying to organise at our wonderful new workplace at Turning Point. And that's a very powerful unspoken message at the moment someone enters the building, maybe in the main entrance way, to say you are safe and welcomed here. Also treating all patients and their carer or family or partner with respect and dignity. Remember that our patients are not here to educate us about LGBTI issues, and we are not here to ask them questions out of voyeuristic curiosity or to try and educate ourselves. We can go and look that up later, or ask one of our colleagues later. Also, it's essential to ensure that there's appropriate access to toileting facilities for our trans and gender diverse patients and visitors and our trans and gender diverse colleagues and staff. So people shouldn't be forced to choose only male or female, because a typical example is someone that might identify as female doesn't feel safe using male toilets because it's not appropriate, and they might be bashed there, but then when they go to the female toilets they get accused of being in there when that they're actually a male and that they're not allowed in there and they're not welcome, and some women have been very angry with them and tried to kick them out. So they're not allowed to go to the toilet anywhere, which is a basic human function and right. Some other practice tips are what's relevant for healthcare for patients. Ask the relevant questions when you're talking with a patient. So we've mentioned a few earlier. So practical ones are, do you practice safe sex? Are you concerned about HIV risk? Because that's what we need to know. It's not who did what to who. That's not the screen. It's are you concerned about HIV risk? And that's essential because we know we can do something. We can link them up to PrEP or PEP or a harm minimisation service. When we're dealing directly with our patients, and this is something I'm personally doing for my colleagues when relevant, or any visitors, is I will use the name and gender that they have requested that they be preferred to be called by, even when that doesn't match their health records, because they might be caught up in a bureaucratic time lag, which is no fault of their own, where their health records haven't been modified to catch up with their name and gender identity. And I listen what their gender identity is, and I have no right to judge that. Everyone's on their own journey, and if someone's very clear that they want to be called he, even though they're identifying as a she, or vice versa, or called they or them, that's absolutely fine, because that's important, and it's harmful. It's known to be very, very harmful if we misgender them. So that means someone might be in a female body, their Medicare says, their health records say they're female, but they tell us they identify as male. If in the health system, if we refer to them as he, we are causing ongoing harm, and they are getting a very clear message that we are not a safe practice for them to be at, so they cannot access appropriate healthcare from our service. It's also important to offer a patient a choice of a safe room during the admission process if they're coming to a residential rehabilitation or detox unit. For instance, it might have an ensuite bathroom or be near the nurse's station in case they're at risk of transphobia treatment from other residents. It's also essential as health professionals that we do not tolerate, and we must be seen to not tolerate any homo or transphobic behaviour, for instance, from other patients in a detox residential setting. And so it's good that we feel comfortable being able to address that. So it can be done in a respectful way. When I've worked in a residential detox unit, a resident might make some slur about homosexuals, regardless of whether or not there's any, that to my knowledge, that any of the other residents are homosexual. I will respectfully go up to that person, and I would never shame in front of other people. I wouldn't ridicule them, I wouldn't put them down, but I would actually try and have a friendly, engaging, brief conversation with them about, have they thought what that would be like, and how, about it's important to use respectful language, and we don't discriminate against people, etc. So I've just pulled up a few references that people can access for the literature search, and I've now got a slide which has some resources in it which are invaluable. It's good to know about these. And the top one is VAC. It used to be called Victorian AIDS Council, but they're now actually growing. They've got some fantastic resources. They've got a great website, which is a great portal to excellent resources, including a resource I think you've all been supplied with written for Victorian alcohol and drug workers, so that's us, for supporting this client group in drug and alcohol services, especially residential services, so resi units, detox units and rehabilitation units. They also run a group which I think is, I might be wrong, but I think it's free or very inexpensive, called Rewired, which is for men who have sex with men who are concerned that their ICE use has gotten out of control. And it's very respectful and culturally appropriately. There's also a number called Switchboard, which is a 1-800 number, and that's for consumers. It's not 24/7, but that's where someone can phone up and have confidential counselling or be linked up to appropriate services in the area. There's also another fantastic resource called Gay and Lesbian Health Victoria. They're funded by the state government. They've got a great website. They organise the Rainbow Tick. And there's a brilliant new service, which is a gender diverse health clinic in Melbourne called Equinox that's run by VAC, and they are doing fantastic things for anyone who identifies as gender diverse who wants a health clinic. There's also a similar one up in Goulburn Valley Health near Warburton. Wodonga, sorry. Oh, have I got that wrong? Wodonga? Yeah, sorry. Which has also got a very good reputation. These are all very new and great to know that more for any of our patients. There's a question, do we think the term homosexual is outdated? Because it could be a pathological term, so maybe we shouldn't use it. It maybe the term same-sex attracted should be used. It's a really interesting one because there's multiple different thoughts, even within the LGBTI populations, about what words should or shouldn't be used. So personally, I think there's no right answer. Some people clearly are still using the term they identify as homosexual and proud to be homosexual. So I don't think it's as simple as that, but it's a very good point and one to be mindful of, that some people might find it pathological.
Okay, thank you so much, Kary. That was so informative, and I must say I've learned a lot today. There are a few more questions, so I think we've got a bit of time, so I will ask those. A question that's come up, and I'm particularly interested in this question because, I have a strong interest in intake and assessment and do a lot of training around it. And with the new intake and assessment documents, particularly in the intake document, there's prompts around gender identification. So we're going to ask, how can we sensitively ask about gender identification, particularly when we're first meeting a client for the first time, for example, in intake, and it might be over the phone as well.
So I don't have the intake and assessment document in front of me, so can you remind me the exact wording on that?
It's just a prompt, so it's up to the clinician to ask the question themselves. So there's no written questions around it, it's just a prompt. So how does a client identify? What is their sexual gender identification, I think it is, and then...
Yep, so without seeing it, it might be appropriate to just use the wording that's there. Because then we're kind of getting consistent responses, as long as it's worded in a respectful way. And I can't recall off the top of my head what exactly is there, but it might be to the patient, what's their gender identity?
Yes. So a simple question like that, there's no question there, I guess. Right, what we encourage in the intake document is about clinicians asking their own questions in their own way. So thanks.
So there's been quite a bit of stuff done about that in guidelines for health services, and it's one of those things that there's no right answer. So lots of health services have added in other, so male, female, other. However, lots of people who identify as trans and gender diverse saying, I'm not other, I don't want to be other, I'm me. That's crazy. And there's multiple different terms different people might use, and some transgender people quite rightly have pointed out to me, I'm a man. That's who I am. I'm not, that's just, if someone says, what gender am I? I'm a man. I was born as a female, but now I'm a man. So I'm not other, I'm a man.
Thanks, Kary. Another question that's come up is if a person was to use PrEP or PEP, when using it, how effective is it if you're using alcohol or other illicit substances, or along with any prescribed medications, for example, if someone's on antidepressants or anxiolytics?
That's a very good question, and it's my train of thinking is I'm not an expert at prescribing them. I haven't done the training in them. I'm not an HIV doctor, so I do actively inform all my patients who are potential candidates about them. I recommend that they contact the service to discuss whether or not it's appropriate, and once they contact the relevant services, then they'll get all that information and find out for them, for their individual situation, whether or not it's contraindicated or whether or not it's an option, and whether or not they need to take any safety precautions. But my understanding is in the UK, PrEP's been used quite widely amongst men who have sex with men at chemsex parties, and last I heard, a public health expert had guesstimated they'd save 2,000 people from catching HIV.
Great. And I'm just going to say thank you so much for including PEP and PrEP in this presentation because, again, because I do a lot of training around assessment, on the assessment there is an area about bloodborne viruses, and if you'd like testing and more information, and one of the prompts is about PrEP and PEP. So I do encourage, as alcohol and drug clinicians, that you are familiar about what these terms mean, and particularly where you can access it as well. Okay, so I'm looking at the time, so we've probably run out of time for any more questions. So I would, personally and on behalf of the audience, like to thank you, Kary, for the time you've taken, out of your busy schedule to come along and share your knowledge with the audience. Look, you've just provided valuable information that will assist AOD clinicians when they, in providing safe and positive care for people from LGBTIQ communities and trans and gender diverse communities as well. So a big thank you to you, and a big thank you to everyone attending today. And before we go, I will just like to say our next webinar is on the 21st of March, and it's called From Clinician to Leader in the AOD. It's on the 21st of March, and it's called From Clinician to Leader in the AOD sector, and it's personal experience and learnings. It's presented by Shannon Bell and Beth Locke, and they're going to be talking about and drawing on their own clinical experience and their development as leaders in the AOD sector. So we look forward to seeing you then, and you can register on Eventbrite. So thank you all for coming along today.
Thank you.